test tube, right? And the test tube is probably long gone in some of these machines, so you can use a piece of tubing that's about this long. So an aerosol, you shouldn't use anything, you can't use anything longer because it'll fail, because the ventilator will think that it's pushing too much flow through the longer circuit, and it'll think that there's a leak somewhere. So you need a small one about the length of 2 aerosol pieces. So when we turn the ventilator on, it boots up and it says, do you want to do a pre-use check? Now, in our manual, it says that you can do that you should do a pre-use check before you put it on your patient. Now, the word is, I can't remember if it should or might be should. That is the operative word, or you can do it before is actually the operative word, before you put it on a patient. Now that means then if you DC'd the ventilator today and brought it into your equipment room, wiped it down, and put a new circuit on it and did the pre-use check now, that is before you put it on the patient. So in 3 weeks, when you have to set this ventilator up on a patient, you don't have to do the pre-use check again. It's already been done. There's an electronic record in the ventilator that says that the pre-use check was done on, February 15th, and there might also be a sticker on it that you would put on the ventilator saying that the check has been done, on certain dates. So you go, okay, I'm just going to turn it on, and when you get this message, you just simply say no. Now, what happens is, and then you delete patient data, and now because we're using a cassette that hasn't been officially pre-use checked, we get this message. So because I don't have O2 and air, I can't, even if I put the ventilator through a pre-use check, it has to go through a complete official pre-use check with O2 and air to clear this message. Now, if you're in a situation like we are now, where we only have O2, when I hit the silence button, it tells me that a pre-use check should be performed or has to be performed to ensure that the expiratory cassette works properly. Do you wish to turn expiratory cassette exchanged alarm audio off? So what it's saying is that assuming that the cassette is working fine, that the ventilator wants to shake hands with that particular cassette just to make sure that it's working all right. If it doesn't, you can still use the ventilator, but you're telling the ventilator, look, I didn't have time, or I was in a room that only had O2, so I couldn't completely do the pre-use check. So consequently, I can't do it. So when you hit the silence button and you say, okay, yes, do you want to turn the audio off? Then what happens is that message will always be there, telling the subsequent users that you weren't able to officially calibrate the cassette, but the ventilator will work properly, assuming that there's nothing wrong with the cassette. You can still go through a complete, a pre-use check, but you will still get a message that says not performed on the pre-use check, and it will have calibrated everything else except the cassette, because it needed, and the O2 cell, right, because it didn't have O2 and air. Okay? So just to follow that, so once again, we DC'd the ventilator, we brought it into a room, we're going to do the pre-use check on it, and so then we initially had that, but we'll start by doing the pre-use check. And do you really want to do it? And I say yes. So to explain what happens during this time, so that we know then the next time I would say, or somebody says, it failed, what failed? It's important to know, man, this thing failed. So if you put a note on it, say it failed this test or that test, so that whoever's going to work on it has a better idea of what's going on with it. So we connect the test tube between the inspiratory and expiratory outlet, and then say OK. And the first error that I'm going to get is not a failure, but it just says not completed, because I don't have any air going in, just O2, okay, because the air is turned off. But it can still do an internal leakage test. It can do a pressure transducer test. So if the internal leakage test fails, there's no circuit on it. It could be the gas modules, O2 and air. It could be the cassette if that internal leakage test failed, or it could be your test tube. Can't be anything else. The pressure transducer test, there's two pressure transducers that sit on circuit boards in here. There's an inspiratory and an expiratory pressure transducer that it tests, and so if that failed, we would know that one or the other failed. Just as a little tidbit, both transducers are the same, so that if I were a biomed person and you said, well, the pressure transducer keeps failing, what I can do is take one out of one machine and put it in here, the inspiratory side. If it still fails, I put the good one on the expiratory side, and I know that the expiratory side pressure transducer failed. The expiratory pressure transducer is a little circuit board about this big with a little teeny little thing on it, and that's the pressure transducer. It's right on the circuit board. It's an electronic pressure transducer, but it still reads pressure. So then it got to the O2 cell and sensor test, and it air supplied, so it can't calibrate the O2. So we have to cancel that particular test, and that, once again, that says not completed. It doesn't say failed, it just said, hey, I'm sorry, I couldn't do the test, so I can't complete it. So consequently, the whole pre-use check will be not completed. So now the flow transducer test is occurring, and the flow transducers, a lot of people think that the flow transducers, if it does fail, is the cassette. There's flow transducers in the gas modules as well. So if the gas modules flow transducers fail, you're going to get a failed message on that particular item. So you don't know if it's the inspiratory side or the expiratory side, but there is a flow transducer in the expiratory side in the cassette as well. So now it says unplug the power cord. And plug it back in again, and when you do that, what it's doing is testing the batteries, okay, to make sure the switching mechanism is all right. So now it says connect the patient circuit and block the YPs. So I would imagine that you've all learned this, because what you're telling me is you don't put a circuit on the ventilator. You probably leave this on as the patient circuit, because all you're doing is testing the integrity of the ventilator. So we'll do the same thing, we'll just leave this on here. But keep in mind that in particular, PICU and NICU, you need to have the patient circuit on here when you do the test. Do you work in NICU, PICU, or just adults? Just adults? It's not as important, speaking as clinician, to do this particular test with the circuit on in the adult world, but what does this test do when you put this patient circuit on, in addition to looking for leaks in the circuit? It also determines what the compressible volume loss is to the circuit, right? And so then when you do that particular test, the ventilator knows how much is lost, and it can compensate for the lost volume. So typically on a patient, for example, that let's say we're an adult patient, we're delivering a 500 cc tidal volume to him. And when we're ventilating him, his peak inflation pressure is 30 and his PEEP is 5. So his ventilating pressure is 25, right, in that case. Takes 25 centimeters or creates 25 centimeters water pressure to deliver that 500 cc volume. Well, generally speaking, a circuit without an HME, without a active humidifier, loses about 2 cc's per centimeter of water pressure to the circuit. So if the PIP is 25, or the PIP is 30 minus the 5 of PEEP, so your ventilating pressure is 25, and you're losing 2 cc's per centimeter of water pressure, you're losing 2 times 25, or 50 centimeters to the circuit. So when you're ventilating your patient, even though the ventilator will say 500 cc's in and 500 cc's out, the patient is really only getting 450 cc's, because 50 cc's is being lost to the compression of the volume in the circuit. Now, in the adult world, 50 cc's, I'm pretty sure is not going to matter a whole lot, particularly when you're delivering a 500 or 600 cc tidal breath. But when is this particular test very important in the adult world? When you're taking the ventilator to the MRI. So when you go to the MRI suite, do you go to the MRI suite with the ventilators? You put on a double circuit, So now you have a double circuit, so that means you're losing 4 to 5 centimeters of, or 4 to 5 cc's per centimeter of water pressure. So let's say it's 5 and your PIP is 25, you're losing 5 times 25 or 125 cc's to the circuit. So if you keep him on the same volume that he was enjoying when he was in the ICU with one circuit, and now you're doubling or increasing the volume even more than that, the loss volume even more than that, now he's only going to get 375 cc tidal volumes when you thought he was getting 500.
Yeah, you gotta bump it up a bit.
So, right, so you have to bump it up by that much, but that's the principle. So if in the MR suite you simply do a circuit test, the ventilator will know how much it loses for that circuit, and it will compensate, so you're always delivering 500, so you don't have to bump it up.
Well, it's easy just to do an extra 25, 50. Just bump it up. You don't have time to really calibrate that.
Okay, all right. But just so you know the principle, right? Now, if it were, what if he was really non-compliant and he was, his PIP was 50 or 60?
Still.
He's still 50 or 60 because he's got cement in his lungs. Now 5 times 60, you're losing 300 cc's to the circuit. So when you get him out of the MR suite and you do a blood gas on him, you wonder, why is his pH 7.2 and his CO2 is 80? It's because you weren't ventilating him during the MR. You bumped him up 50 or so cc's, but that you needed like a couple of hundred cc's to ventilate him. So, it depends on what his PIP is. So in normal ranges, not a big deal. You can bump him up a little bit. But as long as you understand that, oh wait, this guy's PIP is high, we may need to bump him up more than just, the usual 25 to 50 cc's. This particular test is essential when you're dealing with PICU and NICU patients. When you're delivering a 5 cc or a 10 cc tidal volume, it's important to know what you're really delivering. So we connect the patient circuit and block the Y piece. We say okay, and now it's pressurizing that circuit. It's looking for a drop in pressure. If it doesn't see a drop in pressure, there's no leaks, and when it releases the pressure, it measures the volume that comes out. So if it knows that it delivered 20 centimeters of water pressure to the circuit and 20 cc's of volume comes out, then it loses 1 cc per centimeter of water pressure to the circuit, because it's how many cc's divided into the amount of pressure that it was created, and it knows that it loses 5 cc or 1 cc per centimeter of water pressure. So it says, do you wish to compensate? And I mean, if you're doing this, you should always say yes. There's no reason not to say yes. And then the external alarm system, and we're not going to do that. So